Thank you for participating in this webinar. My name is Dr. Sky Lee. I am the Assistant Director of Inpatient Services at California Bridge and an Assistant Professor of Family Medicine at UC Davis. Today, we will discuss the California Bridge model to implementing buprenorphine in the hospital setting. I have no financial disclosures. At California Bridge, our motto is treatment starts here. But really, we should change it to treatment starts now. We need to provide treatment to our patients whenever and wherever they show up requesting help. We aim to provide 24/7 access to high-quality treatment of substance use disorders in all California hospitals. We are currently working with over 50 hospitals throughout the state. Our hospitals are urban and rural, community-based and academic, large and small. We are working in hospitals because opioid use disorder impacts hospitals. This is not new. We have been seeing steady increases in our inpatient and emergency department visits related to opioid use disorder, and it's time that we addressed it. Why would we start treatment for OUD in the hospital? Because 67% of hospitalized patients who use drugs say that they would like to quit or cut back their use. But it can be incredibly difficult to do so. I had a clinic patient who was incredibly motivated to stop using heroin, but it was challenging as her supplier, who also knew she wanted to stop, would drop off bags of heroin at her house. Now, this is less likely to happen if she were in the hospital. She would have the full support of the staff and the providers, and we can also help ease the symptoms of her withdrawal. Hospitalizations are also times when people reevaluate, and this can be a fantastic opportunity for change. We have the ability to link them into care, which they are more likely to do if they have a positive experience with their hospitalization. A recent study also showed that patients with OUD on buprenorphine versus patients with OUD not on buprenorphine had a decreased 30 and 90-day readmission rates of 43 and 53%. I usually like to pause here and talk about why patients with substance use disorders leave against medical advice. This was from a qualitative study asking hospitalized patients with substance use disorder who had previously left AMA why they left. Dope sick as hell. I would rather have somebody saw my leg off at the knee than go through that. As medical providers, we tend to minimize opioid withdrawal because normally it is not fatal. However, it is incredibly painful and challenging for our patients, and this quote illustrates the intensity of these feelings. They've given me Suboxone, and that's helped a great deal. That's huge. If I didn't have that, I'd probably be going out of my mind right now. OUD is a medical condition, and there is no reason why we should withhold treatment if we are able to provide it in the hospital. I ended up going to using because I was in so much pain, and the doctors don't do nothing for the pain. There is a myth that if we as providers give opioids for pain to a patient with OUD, then we will trigger a relapse. The reality is that untreated pain is the biggest trigger for the return to use. Patients with OUD have a higher tolerance to pain medications and may need higher doses. But oftentimes we underdose due to the fear of harm, but we are actually doing more harm by not addressing their pain. Well, I did go there once with an abscess, and they weren't very compassionate with that. They were very rude. They was like, well, maybe you'll think about this before you do this. They make you feel like a criminal because you have substance abuse issues. I feel like I'm an outcast. You always feel like an outcast when you're drunk. People judging you, and you get sick of people having their opinion on you. These last three statements illustrate the stigma and the discrimination our patients face. Most times, they do not feel welcomed by the healthcare system because of mistreatment. Our goal is to change that. We, as healthcare workers, need to be aware of our biases and how our language and actions adversely affect the care that we provide. This is a seminal study by Lipschutz, which showed that by providing buprenorphine in the inpatient setting compared to detox alone, increased the number of patients receiving medications for addiction treatment 6 months after discharge, and increased the number of days of taking medications for addiction treatment over the course of 6 months. This works. Providing buprenorphine in the inpatient setting improves outcomes, period. There have been several studies that show that buprenorphine has a decrease in all-cause mortality for people with OUD. I can't think of another medication that has this amount of reduction in all-cause mortality. Even statins don't do that, and everybody is on a statin. This is our data from California Bridge. Since we started collecting it in April of 2019, we have identified nearly 9,000 individuals with OUD. So, For every 10 patients we have identified with OUD, 7 have received treatment in the acute hospital setting, and 4 of them have followed up with an outpatient visit for continued care. This graph also shows a decrease in numbers of patients seen in the hospital due to the COVID pandemic. Anecdotally, we have seen an increase in use and in overdoses during this pandemic. And it's important not to forget about the opioid epidemic during the COVID pandemic. While we are not going to focus on this today, we do have resources on our website, bridgetreatment.org, on how to address OUD during COVID. Focusing in on California, about 2% of our state's population have an OUD. So say today, all 687,000 people with an OUD said, today is the day. Today is a day that I like to get treatment for my opioid use disorder. If that happened, we would be left with over 500,000 people who would not be able to access treatment. And that's because even with all of our methadone programs, which are usually located in more urban areas, we only have 3.2% of all prescribers in California with an X waiver to be able to prescribe buprenorphine. I bring this up because we need to do better. While we have this restriction on buprenorphine, we need to go out and get our waivers and also encourage all of our colleagues to get their waivers. The number of prescribers would be unacceptable for any other chronic medical illness. I also like to mention that health disparities exist in addiction medicine just like it exists in the rest of medicine. Non-white minorities are much less likely to receive treatment than their white counterparts. So this includes things like antidote therapy for an acute overdose, or even getting prescription opioids for pain, and also getting buprenorphine prescribed to them for treatment for an opioid use disorder. There are also increasing rates of opioid mortality in the non-white minority population. Awareness is a first step into looking at our own implicit biases and eventually making the shift to addressing the disparities on an individual as well as a systemic level. Okay, so how do we do this? If a patient comes to the emergency department in withdrawal, you're allowed to administer buprenorphine or methadone to treat their OUD withdrawal for up to 72 hours without an X waiver. So you can give them a dose while they're there in the ED, but you won't be able to write a prescription for buprenorphine to get them through until their next clinic appointment. So patients who can't get an appointment for a few days will have to keep coming back to the ED to get redosed up to 72 hours. And so this would be a great reason to get your waiver. So you can give them the dose in the emergency department, and then you can write them a prescription to hold them over until their next clinic visit. If a patient is admitted to the hospitalist or the surgeon can give them buprenorphine or methadone while they are hospitalized without an X waiver. And this can be for both new starts and also for maintenance. But similarly, you will need to have an X waiver when writing a discharge prescription for buprenorphine. And for methadone, they will have to follow up with a methadone clinic. But isn't this really complicated? I get this question quite frequently. But in reality, for the emergency department, this is all done in fast track. It usually takes less than 2 hours. And on the inpatient side, starting buprenorphine is a game changer. It calms the patient down because you're treating their withdrawal and their OUD, and it also improves the relationship with nursing because your patient is less agitated. So you do not need to be an addiction specialist to do this, much like you don't have to be an endocrinologist to give insulin for diabetes. It's easy and you can do it. At California Bridge, our goal is to revolutionize the system of care, is to provide evidence-based treatment, to create a culture of respect, and to work together with the community. Some ways we do this is by having a provider champion and having a substance use navigator. The substance use navigator has many different names. They are oftentimes called peer navigators or treatment coordinators. They help the patient navigate through the healthcare system and translate the patient's needs to the providers, and vice versa. Involving pharmacy is also incredibly important. This ensures that buprenorphine is easily accessible not only in the ED, but also from the inpatient floors. Other key groups to engage with are with nurses and with ancillary staff to help support our patients during this difficult time. We rely on this culture shift to encourage patients to self-disclose their use disorder. We have signs and buttons throughout the hospital that let patients know that this is a safe space. Without this shift in culture, we would be unable to do the work that we do. Let's do some cases. The first case, this is your basic 28-year-old male who presents with opioid withdrawal. Let's talk through how we are going to treat his withdrawal and how we will start his buprenorphine. This is just an overview of our algorithm. The actual algorithm is on the left in the boxes. The information on the right-hand side is just for people who want a little bit more information. The algorithm itself is quite simple and we'll break it down for you in the next few slides. For this young gentleman who comes in with an uncomplicated opioid withdrawal, and I'd like to mention that this algorithm is for short-acting opioids, not for methadone and not for anything long-acting. But once we know that he is in withdrawal, we can give him buprenorphine. If he's not in withdrawal, then we just wait until he is in withdrawal. And how do we know when the right time is? We just ask them. If the patient says that he is in withdrawal and there is one objective sign of withdrawal, then we can start. We intentionally took away the CALS or the clinical opioid withdrawal score from this algorithm. We found that it was actually more of a barrier and it delayed care. It was time-consuming and it required nursing or provider training. So the CALS can be useful if you're not entirely sure if the person is in sufficient withdrawal, but most times the patient can tell you that they are in withdrawal and they're ready to start. We also start with 8 milligrams of buprenorphine because we found that it made patients feel better quicker and it reduced the time needed for redosing. Oftentimes we found that 2 milligrams or 4 milligrams would incompletely treat someone's withdrawal and they would be uncomfortable for another hour or 2 or 3 while we got them the next dose of their medication. It's not wrong to start someone on a lower dose, particularly if you have concerns for precipitated withdrawal, but the majority of the time, the initial dose of 8 milligrams works well. Now, after you give them the initial dose, you can wait about an hour and reassess. They should start feeling the effects of the buprenorphine within about 15 minutes. So you can reassess a little bit sooner if you would like, before an hour. But when you do reassess, you ask them if their withdrawal has improved. If it has, great. You can give them a second dose. If the patient is going to be admitted to the hospital, you can give them another 8 milligrams as a second dose, and then the inpatient team can titrate the dose on subsequent days. After the initial day, you're really titrating to opioid cravings and not necessarily to opioid withdrawal. If you're in the emergency department and you're going to discharge the patient home, you can give an additional 8 to 24 milligrams. You can give the higher loading dose of buprenorphine for a longer effect. So, for instance, if it's Friday, or if the pharmacy is closed, or the patient's clinic appointment isn't until Monday, you can give a loading dose so that they can make it through the weekend without going into withdrawal. This is a nice option, especially if their prescription cannot be filled or if the patient can't make it back to the emergency department for the next day for their repeat dose. In general, most people do well on a maintenance dose of 16 to 32 milligrams per day. Now, what if you give the initial dose and on your reassessment the patient is not feeling better? This is a really good time to pause and reassess your differential. There are several things that can mimic opioid withdrawal, things such as flu, DKA, sepsis, or preeclampsia. So if you give your patient 8 milligrams of bup and they haven't improved, take a minute to pause and rethink what's happening. If you gave them 2 or 4 milligrams of buprenorphine as their initial dose, this could be that this is incompletely treated withdrawal and they just need a little bit more bup to feel better and to adequately treat their withdrawal. It could also be that maybe they're feeling a little bit of side effects like headache or nausea, and for that you can just give them supportive medications. Precipitated withdrawal generally happens if they've been on some long-acting medications such as methadone. I've also heard of this happening rarely with illicit fentanyl use as well. But if precipitated withdrawal happens, more buprenorphine will not make them feel better, and the severity of the precipitated withdrawal can vary. But it's okay to stop, and it's okay to give them some supportive medications, and some of that might include full opioid agonists or benzos. And it's okay to trial restarting buprenorphine when more time has passed and when you are sure that they will no longer be in precipitated withdrawal. The important part is that you listen to the patients and try to make sure that they have a good experience not just with this medication, but also with the healthcare system. This way, patients are more likely to come back when they need help. I make sure to give everyone I discharge naloxone. This is a life-saving medication. If you can hand it to them in person, that's even better, as many prescriptions are never filled. I talk about it like I would talk about a fire extinguisher. I don't expect the hospital to catch on fire, but if it does, I'm really glad that we have fire extinguishers and sprinkler systems. And also, if the patients have it, they can help save the lives of others. If it's not for them, it can help save their loved one or a friend. I also document the diagnosis of OUD or opioid withdrawal. And if I give a prescription for buprenorphine, I check our California's PDMP cures and I document it. If you're in the emergency department and you're writing a prescription for less than 7 days, and you do not have to check cures. I also give enough buprenorphine on discharge until the patient can make it to their next follow-up appointment. And during this time of COVID, I am a little bit more inclined to give patients a little bit of a longer prescription to prevent them from running out if there's an issue with the pharmacy or an issue with making it to a clinic visit. You do not need to check any labs before starting buprenorphine. The things listed on this slide should not be a contraindication to starting treatment, and it should definitely not delay treatment. However, I do tend to check some labs when I'm on the inpatient service because usually we are getting some sort of blood work and it's easy to add on. So I'll add on a HIV and a Hep C. Urine drug tests are also meant to inform care, and they're not meant to be punitive. I actually use them more in the outpatient setting, unless a patient is altered, and then I'll check it when they're inpatient. And for all urine drug tests, I talk to the patient about it. If I see cocaine or methamphetamines in the urine, I take that as an opportunity to talk to my patients about their cocaine use disorder or their meth use disorder. I don't take away someone's buprenorphine, which is to treat their OUD, because their urine also shows cocaine or meth. I also make sure to give them a bowel regimen, as buprenorphine is still an opioid and it can cause constipation. I also consider checking immunity to Hep A and B and make sure that their Tdap is up to date. And sometimes I also like to talk to them about, hey, do you want to start PrEP or pre-exposure prophylaxis for HIV? Now, I don't do all these things on the initial day of admission. These are just some things to consider during the hospitalization as an opportunity to re-engage in healthcare. Case number 2. Mr. J is a 57-year-old male with heroin use, and he's admitted for bacteremia and an epidural abscess. He recently left 2 other hospitals AMA, but needs to stay for antibiotics and surgery. On day 9 of his hospitalization, there was white powder at his bedside, and he had some chills, diarrhea, and a runny nose. This case is to talk a little bit more about fentanyl. Illicit fentanyl is becoming increasingly common in all substances. I tell all of my patients to assume that it's in all illicit substances, so that means cocaine, meth, Xanax, etc., and not just in heroin. Some places have fentanyl test strips available so people can test their drugs prior to use. You can get them online or from organizations such as a Harm Reduction Coalition. The high prevalence of illicitly manufactured fentanyl is also why I prescribe naloxone to all of my patients with a substance use disorder, even if it is not a opioid use disorder. I want to address that there is some controversy regarding naloxone efficacy on fentanyl. While we are continuing to gather more information about the effects of illicit fentanyl, general consensus is that naloxone does work on fentanyl. However, there are some nuances such as wooden chest syndrome. It's described in the anesthesia literature when fentanyl can cause rigidity of the chest muscle wall and laryngospasms. The high mortality could be due to the severity of the respiratory depression causing anoxic brain injury, or high levels of fentanyl on the mu receptors, or that there wasn't sufficient time between naloxone dosing. But you should still give naloxone to all of your patients and advise patients to use naloxone for any suspected opioid overdose. If you have a patient who would like to start buprenorphine but knows using fentanyl, most times you can use the algorithm as discussed above. You can also consider starting with lower doses or consider microdosing to decrease the risk of precipitated withdrawal, as fentanyl is lipophilic and can sometimes stay in the fat stores. Case 4. Ms. K is a 65-year-old female with chronic pain syndrome due to a remote MVA as well as severe bilateral knee osteoarthritis. She's on buprenorphine for OUD and she's admitted for a right knee replacement. A common question I get is, how do you manage her pain and what do you do about her maintenance dose of buprenorphine? We always want to continue a patient's maintenance dose of either methadone or buprenorphine during an acute pain episode, so that can be from a surgery or labor or fracture or some other traumatic event. You can always increase the dose or split the dosing TID or QID to help with the analgesic effects, but we do not recommend stopping it. Their maintenance dose of buprenorphine or methadone is not sufficient to treat their acute pain. Stopping someone's maintenance buprenorphine or methadone has a risk of the patient going into withdrawal, increasing cravings and anxiety, and increases the risk of return to use. It's incredibly difficult for patients to stop their maintenance medication and to restart it. I had a clinic patient tell me that she would rather forego a knee replacement surgery that would help her with her overall pain and mobility than to go through her prior experiences of tapering off or restarting after surgery. We advise the use of multimodal analgesia, so that includes a variety of non-opioid medications and the use of full opioid agonists if we needed for pain control. There were several studies done on large joint replacements and with C-sections for people on maintenance buprenorphine or methadone compared to those who were not. Continuing the maintenance buprenorphine and methadone and using short-acting full opioid agonists work to control patients' pain without increasing morbidity or mortality. The amount of opioids needed to treat the pain was higher than their counterparts not on OUD maintenance treatment, and that was largely thought to be due to tolerance. As providers, we can be afraid to treat the pain as we are taught that it may trigger a relapse for someone in recovery. However, the largest trigger for relapse is untreated pain. This is our algorithm for acute pain management for patients on maintenance buprenorphine. As you can see, we can continue their buprenorphine and acknowledge that we will be treating their pain. Oftentimes, pain is ignored in this patient population, and telling them that you will treat their pain and that you will take it seriously can help ease their anxiety. If there are no contraindications, I will write for around-the-clock alternating acetaminophen and ibuprofen to help control their pain at a baseline. It also decreases the amount of full opioid agonists utilized. Sometimes I will add on gabapentinoids, and if they have a PCP and I am suspecting an underlying concurrent diagnosis of depression or anxiety, I will oftentimes start an SNRI or a TCA. Sometimes I will call for an anesthesia consult to help with a nerve block. You can also use ketamine, IV lidocaine, and magnesium, but those are generally reserved more for the emergency department and for critical care rather than the med-surg units. You can always increase their dose of buprenorphine and also use full opioid agonists if the above do not work. If you add on full opioid agonists to someone who is already taking buprenorphine, you will not precipitate withdrawal. Pregnancy. While not everyone listening today does prenatal care or is in labor and delivery, oftentimes we as hospitalists are consulted on a medical issue for someone who is pregnant and admitted for things such as pyelonephritis. This is a California British quick start algorithm for buprenorphine during pregnancy. It's actually not much different from the one that we had discussed earlier. It just has more information in it in regards to pregnancy. Starting medications for opioid use disorder during pregnancy is extremely satisfying as your patients are incredibly motivated. It is important to note that there are more pregnancy-related deaths due to overdose than due to preeclampsia or hemorrhage. The key points here is that buprenorphine and methadone are safe in pregnancy and safe in breastfeeding. They are both recommended by ACOG. It is not recommended to provide detox only without the continuation of maintenance treatment. While in the past we have largely only used a buprenorphine mono product during pregnancy, we are seeing more evidence for the safety for the combination product buprenorphine naloxone. Many experts advise shared decision-making with your patient on whether to use the mono or the combo product. Regardless of the formulation, you may need to increase the dose of buprenorphine in the later trimesters due to increased metabolism and plasma volume. A buprenorphine start alone does not require admission to the hospital or fetal monitoring. However, depending on the patient and the hospital, some providers offer a hospital admission for a buprenorphine start if the patient would like increased support. For those of you that are interested, we have a more in-depth document for trauma-informed care and for medications for opioid use disorder during pregnancy on our website, bridgetreatment.org. It's under Resources. It can be daunting to start a new medication, and I want to assure everyone that you are not alone. If you are in California, Clinicians can call the substance use line 24/7 for expert advice on a specific patient case. It is through the Clinician Consultation Center at UCSF and the California Poison Control. If you are outside of California, clinicians can call the National Substance Use Warm Line during business hours. If you call outside of business hours, you can leave a voicemail and they usually respond the next day. You can call these experts on any questions related to substance use disorder that you may have, whether or not it's inpatient or outpatient. It's an excellent resource for both new and experienced clinicians. My take-home points are that patients in the hospital already have substance use disorder, and we need to treat them just like any other chronic medical condition. Buprenorphine and methadone saves lives. You can start methadone and buprenorphine in the hospital for OUD. It's easy, and it is definitely within your scope of practice. A SUN or substance use navigator is valuable and can help connect patients with community resources. However, that should not be a deterrent if you do not have one. You can still do this in your hospital without a SUN. Treatment for OUD is easy and you can do it. Thank you for listening to this webinar. If you have any questions, feel free to contact me via email. You can also find our resources on our website, bridgetotreatment.org.